All right. Well, good evening. I'm so glad that all of you have joined us today for the kickoff of our 2024 Community Engaged Research Summit. The theme of our summit this year is building income and career momentum to achieve health equity. So we hope you think that this is a novel topic. We did, and we're going to learn a lot over the next couple of days. So I want to do a little housekeeping before we kind of get moving. First, a blessed Eid Mubarak to all those who celebrate. So we start with that. I also want to provide what we call a radical welcome. Probably as we move forward, hopefully won't be as radical, but we always want to make an effort to make sure that everyone feels welcome in this space. Like I said, we are glad that you're here and joining us and participating with us today. Our radical welcome really also focuses on those in our community and our audience who identify as transgender, non-binary, and gender non-conforming. And we want to remind everyone that a person's purposeful gender expression or external appearance may not match their internal gender identity. So in this space, we want to use the appropriate pronouns. For instance, mine are she or her. It's on my next to my name in my little thumbnail. We're committed to not making assumptions about anyone's gender identity based on the way they look, sound, or behave. Feel free to ask people what pronouns they use and share your own. When in doubt, use neutral pronouns, they, them, theirs, and please respect what people want to be called. And if you make a mistake about someone's pronoun, make the correction and move on. So we always want to start our summits with that piece. I also want to do our land acknowledgement around the legacy of Native peoples. Wayne State University rests on Wawayatanang, also referred to as Detroit, the ancestral and contemporary homeland of the Three Fires Confederacy. These sovereign lands were granted by the Ojibwe, Odawa, and Potawatomi and Wyandot nations in 1807 through the Treaty of Detroit. Wayne State University affirms Indigenous sovereignty and honors all tribes with a connection to Detroit. So thank you for attending to that with me. So again, welcome. This is actually our fifth Community Engaged CEnR Summit. We like to say it's annual, but there have been a couple of years that we skipped, but this is our fifth one. And again, our theme is building income and career momentum to achieve health equity. It is sponsored by Wayne State University and the Center for Health Equity and Community Knowledge in Urban Populations. We also call it Checkup. A lot of you I know are affiliated with Checkup, and Checkup is committed to advancing academic community partnerships towards health equity programming and research. It's also sponsored today by Kermanos Cancer Institute and our Office of Cancer Health Equity and Community Engagement. So again, committed to building sustainable, transparent, meaningful partnerships between our academic institutions, our hospitals, and our community stakeholders. So what we're working on are our summit over the next 2 days, I think is very aligned with the work of both of those entities. And we start out tonight with our program, a panel about having a career as a community health worker, starting out and staying in. We have a really great panel for you this evening. We're going to talk a lot about community health workers, and I think it's important. It's very much aligned with the theme because it is career focused. So I'm really pleased to pass the mic on to one of our great colleagues at the Southeastern Michigan Health Association, Arthur Hampton, who's the Health Equity Director at CEMHA. So I will turn it over to Arthur.
Good evening, everyone. I am so glad that everyone's able to make it in on this rainy evening, and I'm looking forward to the discussion tonight. And it's really important that we raise the visibility of the great work of community health workers and their impact that they have on the community. It goes without saying just the way that they are able to navigate and help people transcend their circumstance. So with that, we have three amazing speakers tonight. Miss Philesha Gough, who is a native of Mount Clemens. I will let her introduce herself. And then we'll have Dr. Opara, and then Dr. Somers, and then Dr. Hayley Thomas, who just introduced herself. So let's go with Mrs. Gough.
Oh, it's Philesha Gough. That's okay, Mr. Arthur.
Gough.
Yes.
I
That's okay.
asked
Just
that.
like
They
the game.
said go. They said go
No,
like Geo. I asked. Okay,
no,
I tried to
golf
get it
like the
right. All right.
game. I
Miss
am so
Philesha
glad
Gough.
to be on the panel with these wonderful panelists and participants. I come to a community as a community health worker a roundabout way. I do have a master's degree in instructional technology from Georgia State University and got my undergraduate in manufacturing from North Carolina A&T, a historically Black university. And I just kind of, meandered around. I was working in manufacturing, working with Focus Hope with their training programs back in the 80s, and decided to make a move in the early 90s to Atlanta. And that's where I got my master's degree in instructional technology, focusing on video conferencing, long distant learning at that time, and just helping older adults learn and find where their niche is and the like. So I've worked in that space for some time. And then I've kind of transitioned back in 2008. I have a mentor, and she's also my pastor. She was an executive at Henry Ford Health System, working as the director of Faith and Community Nursing Network. So she encouraged me to take the prep class. Although I'm not a nurse, I'm a health minister, and that was bridging spiritual care along with the physical care of a person, and particularly people in congregations. So I was exposed to doing healthcare screenings, blood pressure screenings, foot care screenings, and the like. And then I went on to get my certification as a CDC diabetes prevention lifestyle coach. And from there, Imelda is her name, Imelda Brown. She encouraged me to get my CHW certification. She just thought it would be a great fit along with the work that I was doing in the diabetes prevention space. And from there, I've always had a desire to work in public health, work with people. It's in my DNA, working in the community. I come from a long line of community activists. And so I just kind of did certain things, worked in as private duty, health aide, and then I got a position working in a senior skilled nursing facility, worked in activities working with seniors with dementia. And from there, I was able to get a position with Henry Ford on a contingent basis, again, working as a diabetes lifestyle coach, working on various projects, advanced care planning. And I just saw that that was my niche. And on my own, sought out other teaching opportunities, facilitating opportunities with the Area Agency on Aging. So I do have experience working with fall prevention, diabetes prevention, chronic disease prevention, and just lately in the last 3 years, I've worked full time with Henry Ford on community engaged projects, research projects, one with the University of Michigan, helping seniors to manage their pain within the Detroit area. I'm currently working on a pilot program within the Henry Ford Health System, servicing our North Market, primarily the West Bloomfield and Commerce area, connecting seniors to resources that are in need of support, and as they are, caregiving for themselves as well as other family members. So that's what brings me to the community health worker field. We are frontline public health workers, but most importantly, we are concerned about our community. We have both lived and shared experiences, and that's what we bring to the table. And thank you.
Thank you. Dr. Opara?
Yes, can you hear me okay?
Yes.
Wonderful. Well, greetings, everyone. Good evening. And I just want to say thank you for allowing me to be here and share space with this highly esteemed panel, every which one I have worked with except Ms. Gough. I am Gough. We were corrected. And I'm looking forward to learning so much about your work. So again, greetings to everyone. My name is Dr. Ijeoma Nnodim Opara. I am a physician, scientist, activist. I am an internal medicine and pediatric primary care doctor with Wayne State University School of Medicine, and also affiliated with Detroit Medical Center and Wayne Health Physicians group. My mission in life is to see about the elimination of white supremacism and anti-Black racism in healthcare, the sciences and academia, and the public health system, while centering Black brilliance, Black abundance, and Black joy. And so this informs the work I do in clinical practice, in teaching and education, in research, and in community organizing. In terms of community health worker work, I'm very honored to partner with our community health worker staff as part of the Wayne Health Mobile Health Unit to provide training in social determinants of health, assessment, screening, delivery, connection to resources, and to provide that on an initial and ongoing basis, as well as developing a model for how that is done in a way that is culturally affirming, that is equity-centered, and that ultimately lifts up the integrity and the dignity of the people we're taking care of. I also am honored to be a co-chair of the CHW Equity Action Group of our NIH, that is National Institutes of Health, Health Equity Action Network, as part of a large NIH grant addressing cardiovascular health equity. And to that end, I work with others around the country to really create what best practices look like in terms of integrating CHWs in research, health equity research specifically. And last but not the least, I'm really honored to work as part of Checkup to create a CHW clinician roundtable series to really begin to lift up the ways in which we need to be more intentional as to how we integrate CHWs within the healthcare system as part of as a critical part of the health care team. And what does that look like and mean? And how do we create those systems that work for all members of the healthcare system, again, with CHW as the central part? So with that, I hope that it informs valuable contributions to this discussion. But more importantly, I'm looking forward to learning from everyone on this panel, as well as everyone that is in attendance. Thank you.
Thank you, Dr. Opara. Dr. Somers?
Oh my gosh, can I just second everything that Philesha and Ijeoma just said and just like go for the night? I'm just kidding. No, you guys were great. So I just literally am so inspired by what you're talking about. And Hayley, Dr. Thompson, thank you so much for inviting me to be part of this. My background is in mental health. I've been working in K-12 and community clinical populations with K-12 and community populations for almost all 30 of my years in the field. I've been at Wayne State 26 years researching and teaching in these areas, training mental health practitioners and feeling like there's a gap. Like, you know, the mental health practitioners are available only to a few, right? It's really hard for people to get in and get the services that they need. In the past decade, I've been working in more of a community health space with our community Center for Health and Community Impact at Wayne State, which is part of the kinesiology, health and sports studies area. It's where our community health area is. And I've been working at the intersection of physical and mental health and wellness and how important those things are. And I started meeting everybody in this group through work with the Office of Women's Health. And in the past 3 years, my partner, Nate McCautry, who is in community health and kinesiology, we developed the Community Health Worker Academy because we got involved in the community health worker role as a more effective role than perhaps just isolated roles in psychology, for example, or straight community health. And that complementary role in helping folks reach their health goals and reduce health inequities by having better access to health resources and services. And so we developed our Community Health Worker Academy to help with projects involving reduction of hypertension. That's how I met Ijeoma. developmental disabilities and vaccinations. And now we're writing a project on sleep and like people that have multiple chronic conditions, including sleep and hypertension. And we know there's such health inequities and earlier death rates, right, around these things. And so we're working in projects on neighborhood wellness centers and aging research centers, substance abuse. And even I was just working on a new project with a woman who wants to do mental health work through community health workers in barber shops in the Detroit area. So we're just expanding in so many great areas. And the central theme is the role of the community health worker. My personal bent is mental health, and I feel like an activist about this. I feel like being in the a la Bettina Love, a co-conspirator and a disruptor around all of this, and advocating for the important workforce of community health workers and the impact that they have. And so that's kind of, I don't know if I explained it well enough where we are and where we're going, but this is what is inspiring us these days in our area of community health and our Community Health Worker Academy. Briefly, we have a training component and then an upskilling or professional development component to our work. And it's called an education catalog, and there's a lot of complexities around it, but we're just really working to develop that workforce because of all of the impact and potential that it has already demonstrated. So thank you for inviting me to be here today. Like Ijeoma, I want to learn from everybody and then share what we've got going on.
Thank you, Dr. Somers. Last and certainly not least, introducing herself, the illustrious Dr. Hayley Thompson.
Thank you. I'm very humbled actually to be on this panel. I'm much newer to the community health worker space. I really I introduced myself before. So I'm a professor actually in the Department of Oncology here at Wayne State, and I have a few roles in directing community outreach and engagement at our cancer center, Carmanos Cancer Institute, and I'm a director of Checkup. You know, one of the both of those institutes are helping to host tonight's event. So I come to this space a lot because of work I've done with lay health workers. So that's kind of was my first foray into this work, because I very much very committed to capacity building. I talk about that all the time. And how do we provide people who are not necessarily degreed in kind of a health profession or in this space, how do we provide people with skills and resources to still participate in healthcare kind of in the broadest sense, and to support health education and promotion in diverse communities. So years ago, I started working with a program that we called the Witness Project. It was a national project that focused on teaching lay health advisors, again, lay people, women in the community, to teach other women about breast and cervical cancer and help navigate them to care. So, and I really feel very strongly about providing those kind of opportunities to people, just to allow people to teach and to share information and share resources and to be partners with healthcare institutions and academic institutions in this work. So that's sort of how that's one of the kind of the pathway through which I come to work with community health workers. We've been able to really advance this in the research realm, because I'm largely a researcher. So through my colleagues and my team here, we've developed a Building Your Capacity curriculum, so we could start teaching people about research and how to get more involved in the research enterprise and then with academic research, and how to partner with academic researchers. And that then evolved into, that was sort of like our introduction to research. It is a 9-session course that people can take even now, a 9-session course that, again, introduces people to the jargon and concepts in research. And then we took it even further with our Community Health Scholars program. And that takes people even more in depth into the research enterprise in terms of building and applying research skills. And, you know, it's been a really interesting opportunity because, again, it goes beyond even preparing people to partner with researchers, but we're starting to think of it now as how can we prepare people for even careers in research, because there's a lot of space in this area to bring in different voices and different perspectives, especially those that represent our communities. So we really are now starting to look at the Community Health Scholars Program and the Building and Applying Research Skills course as maybe a starting point for building a career in research, and that's for lay people. But I think it's a really unique opportunity for community health workers to maybe diversify their activities and what they do. So that's how I'm kind of participating tonight.
Thank you. All right. Well, we have a list here of about 10 questions, and I am looking forward to getting started. I'm going to ask the question open, and whoever has the answer, please step up. First question, for those that don't know, what is a CHW, and how did it come to be a field?
Is that a good one for Philesha?
I don't know all the history. It goes back to the 60s, but if you want to go even further, they took the model from Africa, how people would engage with the community. You had key people in the community that folks trusted. They were the trusted messenger. And from that model, it was developed, I guess, in the States as a community health worker model, but the model goes back to Africa, taking care of your community. You have trusted people that you can go to if you have whatever issue, whether it's spiritual, physical, emotional, and they will be able to provide you with that support. So from that, with that being said, the community health worker, the textbook model is a frontline public health worker. And what we are, we're in the community, a trusted voice, a trusted messenger. And working in the space where I'm coming from, I work in a health system, and I have experience working with seniors. So they look at all that experience of me working with seniors, my background, and with that population, and because I am a senior, I'm able to identify and work along with the senior population some of the issues that they may be facing. Most seniors are facing chronic disease, and I have that background in diabetes and have knowledge of hypertension and how all that connects. Some of them are spiritually distressed, and I do have that background as well. I'm a health minister, and I'm an elder in my church, so I understand the connection of whole person. So with that being said, I'm able to connect them to resources given the information that's presented to me about their health status. And what we do is we connect with, in my particular situation, I connect seniors. I look at what's internally, because I work for Henry Ford Health System, and then I look externally for resources. And that could look like Meals on Wheels, if there's a food insecurity, if there's a caregiving need, there's resources out there to support them with caregiving help. A lot of them are caregiving for others, and they're not caring for themselves. If there's a need for dementia or Alzheimer's support, there's also resources. So it really depends from what I look at. I use the acronym from nursing, the PI, the problem, intervention, evaluation. So once I'm presented with the problem, then I look at various interventions to help them, and then I'm constantly communicating with them to see how that intervention is helping. If it's not, we go back to square one. So that's my nutshell version of community health work. One of the things you do have to have is passion and caring, understanding, being culturally sensitive. Right now, I'm working in a market where it's primarily middle-class white people, but I can work with anyone because I have the skill set and I'm culturally aware of what the needs are.
Thank you, Dr. Opara.
Yes. Snaps. Everything Philesha said. And I'm going to put a link in the chat. Anyone who knows me know I'm on these social media streets trying to, stay young forever. And so I actually did a TikTok on who is a community health worker to lift up the vital role of community health workers in our public health and healthcare system. And so I just really wanted to, I'll put that I was trying to multitask, and I forgot that God told me not to multitask no more because it's not doing me no favors. But in any case, There was a question in the chat that I think is really worthy to bring up. Dr. King Z asked a very important question around what is the difference between a lay health advisor and a community health worker. Nan, it is synonymous. So there are multiple words and terms for community health workers. You will hear lay health advisor, you will hear community health connector, you may hear community health representative, you may hear a health promoter, you may hear promotoras, especially in the Spanish-speaking communities.
Yes.
And I want to lift up, given that this is Black Maternal Health Week, starting today, ending on the 17th, doulas are community health workers, and doulas play a critical role in maternal health equity. And we're seeing a lot of, and we'll go into this conversation later in terms of policy and laws and reimbursement and all that, and how it features with all these pieces. But I want to lift that up, especially in a week like this week and this month, April being National Minority Health Awareness Month as well. So they play a critical role in health equity, in health justice, in eliminating health disparities, and they go by many different names, but they all do the same thing, which is to really represent the communities that they come from as a liaison with the healthcare and the public health system, and just be passionate, vivacious, amazing, stellar advocates for the communities that they serve. I'm truly grateful to community health workers by whatever name they go by.
Yeah. The only thing I would add to that is the distinction that we can make now is that there's a certification now for community health workers. And so that's something we'll get into.
I think that's a great segue for Cheryl to come in.
Yeah, I mean, I know Arthur's managing the questions, but my last thing I want to say about this is that I love that, Philesha, you brought out that the origins of the CHW come from other cultures than the American culture that is across all of our, all of our contexts. But it long before CHWs were invented, I guess, in America. I mean, the literature, I've been doing a lit review for a big study we're writing, and there's so much literature from other countries, India and Africa, even South America, Asia. I mean, a lot of really interesting things have been going on, and we're not the first to think about this. So I think I really want to lift up what Philesha's saying there. And so I think I'll stop at that moment.
Yeah, no, I as a Nigerian, yes, like when I started hearing about community health workers here, I'm like, oh, yeah, that's what Big Mama used to do in the village. We have such a long history. So yes, it's such a critical point. That piece is so important.
It was great.
Okay.
And Arthur, I'm gonna stop because you can guide us, because we're gonna take the horse and run.
Well,
if you
I was just about to jump in there.
You need to corral us.
You kind of bobbed and weave a little bit and kind of hit on different paths. Can you talk about career paths for the CHW? Think about traditional and non-traditional trajectories. We know that people come from varying places to the field, but once you come to it, what are some of the career paths if you're choosing a life as a CHW?
For what, you can go into nursing, you can go into research, and what I'm finding, like community engaged research, because you're involving the community. You can go into social work. It really depends. I think for CHWs to elevate to the next level, you do have to be degreed, whether that's a public health degree or community health. You need some kind of degree in order to gain entry, to elevate. You don't have to have that degree to gain entry. Anyone can come in with that lived experience and come in as a CHW. But if you really want to grow and expand your career options, I just recommend that they really work towards getting that either social work degree, especially in healthcare. You have to be licensed for a lot of stuff. Masters of Public Health, community health educator. So you can come in at a different angle, but if you just want to get beyond the CHW, it's a great foundation, but in order to move, you're going to have the extra experience, and particularly you're going to have to be degreed.
So Philesha, what is your experience with the proportion of people that are fully satisfied with the CHW role, and it is what they want to do. And so like I've been experiencing tension, and I was at American Public Health Association last year, tension between people saying that the universities are just trying to take over and make everybody think they have to have a degree. Arthur, we may be getting ahead of things here, but I think it's a good time.
Go for it.
And then like giving true honor to it being a profession, a legit profession that people can have without having that pressure. And of course, everybody wants to keep, I mean, a goal for many people is to make more and more money, right? And have more and more status. But what about people who are satisfied with the role and satisfied with the salary? What proportion do you see as that versus wanting to do? And when I say more, I don't mean more as if less is negative, right? It's not less, it's not more or less, but so we've been operating from the vantage point of, yes, we absolutely want to encourage career pathways for those who want it, but we want to celebrate those who are happy and feel very validated by this role. So I'm just wondering what your thoughts are on that. And I know I'm not the questioner, but you know, it's just a good dialogue, I think.
I think that's their choice. Coming from the space that I came from, Henry Ford Health, I started off we have a department called CHUD, Community Health, Equity, and Wellness, led by Kimberly Dawn Wisdom.
Oh.
And I came in working on community engaged projects. It was a knock and check project, checking on seniors. I did some telehealth as a CHW, connecting them to their PCP via a video conferencing and the like. But if you're comfortable with that, we do have people that are comfortable working with maternal health, and they don't want to get degree. They're good with doing their day-to-day, but at the end of the day, if you want to go higher in like a management position, that's just the name of the game. You're going to have a degree. If you want to go in training, there's opportunities to train other CHWs, but those trainers are degreed. So that's the person's preference. Like I said, I came with a master's degree, already doing some training, working with various populations. That was my entree into I tried going into nursing. It didn't work for me. So I got my CHW. I mean, I got entree in with experience working in a SNF, a skilled nursing facility. And then, like I said, with Faith and Community Nursing Network, that was foundational. That gave me entree. And once I got my background in a lifestyle coach for diabetes prevention, and Imelda had foresight and say, hey, you're going to need the CHW in order to really navigate in the healthcare space. So I did that. And now with me in the healthcare space with a master's and a CHW, I was able to kind of, maneuver, into the role that I'm in right now. But I don't think I would have gotten to that place without at least a bachelor's degree as a senior navigator in the role that I'm working in right now. So
I appreciate that.
So hold on, Dr. Somers. Hold on, because this is a good place. This is a good place to segue. Can you kind of talk to us a little bit about those key skills? Because it sounds like research and nursing and all of these things can be a potential pathway. But what are some of those key and core skills that are necessary to be a CHW?
You really have to be concerned about population health and bridging the gap of health disparities, making sure that people are getting the information that they need in order for them to have healthier health outcomes. I'm very passionate about that. In my community, as well as other African-American communities, we're dying of disproportionately of all kinds of chronic diseases, mainly diabetes, hypertensive, heart issues, mental health, all those things I'm passionate about. So I'm in a space where I'm in the healthcare system getting real-time information adequate information, letting people know why it's important for you to go to your doctor. Make sure knowing how to have the conversation with your doctor about your health, and how to make sure that you have healthier outcomes. So because of my passion and I'm in that, I love health. I want people well. If there's a barrier to you getting a monitor, I can make that happen through the Faith and Community Nursing Network, because they're working as parish nurses with the healthcare system to make sure we're bridging that care gap.
Thank you. Dr. Thompson?
Yeah, I just want to mention, just going back, and I appreciate, really appreciate this dialogue. Going back to what Cheryl was talking about, though, I just want to acknowledge that, there are people who get that CHW, that base training, and that's where they are happy staying. And I know that we have colleagues, David Underwood with the Detroit Community Care Network, who focuses on bringing in seniors, right? People who retired and who have, want to give back and are still vital, but they're just not working the traditional, of 9 to 5, traditional 9 to 5 anymore. He's bringing them in to be trained as community health workers. I know, Arthur, I'm going to make you a panelist now. You're doing that work too. Maybe you could speak a little bit to that. How do we bring other populations into this who, and again, those are folks who maybe don't want to go on to get get a social work degree or something like that, but this really works well for them.
Right.
Yeah, and those are the differences in roles and settings, like the spirit of Arthur's question. So I was thinking highly of exactly that. Detroit Community Care Network, David Underwood's faith-based network, and we've probably trained 30 or 40 CHWs who are seniors who are really like invested in their communities and have that trust and that bond, and they can be that conduit or that forget, Philesha, what word you use, connector. And we're also like, I just have had some people coming out of seemingly nowhere. Just this one guy he lives in a senior subsidized housing facility, and he's trying to work with a grassroots effort to get CHWs hired in these senior subsidized housing complexes. And so we're working to get him an internship there, and then he's in our training now, and he's going to be like a pioneer spearheader of this role in a place where they don't even have a role. They don't even have somebody getting paid in that role, let alone volunteered. And so I think that's cool. And Philesha, between what Philesha's saying, all of us together are answering Arthur's question, that there's a lot of variations in the types of roles and settings and pathways, and the pathways are exponential if you want them, and they are at the level of the core training if that's where you want. And so like that, I love giving that like spiel that it's up to you, have the autonomy and agency to choose what you want. And Philesha brings up awesome points that you can take it farther, and but farther is just, it's just different, so.
Right. This depends on what your goals are, what you're trying to achieve. So you can still be impactful with just a CHW, second career, mid-career person working in a senior high rise. You're still needed. If you want to take it to the next level of working in community engagement research, you're going to probably, you will get the exposure, but if you want to become a researcher, you're going to probably will have to have a bachelor's degree.
So let's ask the question then. How do I get certified as a CHW? Can you talk to me about getting certified and what that process looks like?
I know for me, I went through MISHWA, the Michigan Community Health Worker Association. That's how I got my certification. That's what I'm familiar with. I know there's other nonprofits that are doing it, offering it, but I went through MISHWA. Okay,
and Wayne State's doing something too, right?
Yeah, we developed our Community Health Worker Academy, and right now for maybe the next 6 months, we have still a decent amount of funding to offer community health worker training under our federal grant that would pay for you to get the training. We've got spots reserved for Hayley's project, and that's exciting. And but we still have room for others. And then after that, we're working on additional funding to advance the workforce through various workforce development initiatives and other funding mechanisms. But eventually, we'll also have a fee-for-service type of arm. And so, yes, we have a really interesting model where you have a three-part program: A, the initial training; B, an upskilling. Federal government calls it upskilling. It's professional development, and we have an education catalog where you can specialize. So you get the core training that's kind of general, but great and detailed, but general. Everybody gets the same training, but then you can specialize, say, in diabetes or hypertension or trauma or aging issues. And then we have specialized certificates, and we have a host of trainings that you go. And then we also supervise field placements, whether they're internships or formal U.S. Department of Labor apprenticeships. You have to have arrangements with agencies. We have 9 agencies that we work with that have U.S. Department of Labor sponsored apprenticeships that we supervise. So we've got this kind of training package that we have developed, and we're constantly evolving and trying to figure out what's the best training model, and it's pretty exciting.
We have a correlating question here in the chat. What does CHW training get you?
What do you mean by that? Where does it get you?
Yes. Could you please explain what the CHW certification gets you? Is it required to do some things? If so, what?
So historically in Michigan, we've had people functioning in the role of the CHW in a variety of ways for decades. But now they're billable by Medicaid. And so entities that are able to bill Medicaid for the services of a CHW want you to have the CHW credential, because otherwise they can't bill for reimbursement for your services. And the types of things that the CHW is reimbursable for your services is screenings like social determinants of health and basic health care related screenings. And then the activity of giving people health resources and kind of health lifestyle coaching, and then connecting them to care and resources that you learn about through a variety of entities like United Way 211 or Michigan 211. And then closing the loop by following up and helping those people like connect the dots and not get lost in the system, and giving them that like very personalized care that they're going to trust a lot more by somebody who understands or came from the community. And so those are the things that are essentially reimbursable. And so getting the credential now in Michigan as of the last year allows you to be hired by companies, healthcare companies, and eventually, hopefully, community-based organizations that will get the ability to bill Medicaid for your services. And then it just kind of legitimizes the whole thing, because now you're actually reimbursable on par, not on par money-wise, but on par with everybody else in the whole medical field that provides legit services. And it's showing now the CHW provides legit services that need to be reimbursed and paid for and invested in for our people. Does that make sense?
Yes, and that's a great dovetail into the next question in terms of how do community health workers navigate these opportunities for advancement and professional development within the field? How do they do that?
You got to be really keyed into what's going on within your organization. Ask questions. Just be aware. Just ask questions. Network. That's how I get. That's how I got involved in various projects. I just kind of always asking questions, aware of what's going on. When we have staff meetings, hub meetings, they said there's an opportunity. You need to fill out this interest. Write a paragraph, and that's what I did. So from that, I was able to be engaged in some research with some University of Michigan researchers on chronic pain management, using trackers to track people's pain, and also provide classes, health coaching on better sleep, reducing stress, using music as therapy, So that's because of my interest. So that's, you just have to really be engaged, networking, talking, asking questions, and that's how you find out what the opportunities are or where they are.
I'm
I
also
wanted
going
to also speak. Oh, go ahead, actually, Dr.
I was going to
Thompson.
throw it back actually to you and Arthur, actually, because I know that, CEnR has networks, right, to support and mentor community health workers who are doing work with Dr. Opara. So maybe you could also talk more about that, because I think networks are going to become increasingly important to supporting community health workers as they grow and move forward in their career. So I was going to actually just throw it to both of you.
Oh, okay. Thank you for that. Actually, Arthur, would you like to speak on the network piece? I was going to bring in a different perspective. So, Arthur, please.
So in terms of networking locally, CEnR does quarterly CHW appreciation events. And so I think our next one is May 17th. And so you can certainly, I'll drop my email here in just a sec, but certainly link up with me and I can connect you with that, share that information with you. Our appreciation events really give us an opportunity to support and share with each other and learn how, the needs and how we can better support CHWs, but also give you a chance to have a good meal with your peers, talk about what's going on. Our last appreciation event, we had Molina Healthcare come in. They did a presentation. They really gave some really powerful information about resources in the community. So that's one of the ways is get connected to the hub. CEnR is, really working to be a hub for CHWs for resources, support, and opportunities. So connect with CEnR is also low-hanging fruit for that as well. Dr. Opara.
Yeah, thank you, Arthur. And to sort of build on that, in one of the ways that we're constructively working together and collaborating on providing that support infrastructure that is of use for our community health workers, but more so even thinking, again, on a higher level and through the equity lens, where it's not just providing support for community health workers, but again, going back to the comment I made in the chat, that they have incredible expertise for their pre-existing healthcare system. And now that they are, again, now sort of because of the reimbursement structure that has been put in place, are more than ever valued and valuable in the system, in our current system. You're valued and valuable when there are dollar amounts attached to your work. Unfortunately, that's just the reality of America. So them being part of the healthcare system in a meaningful way, we also recognize that a lot of times folks don't really know what CHWs do or how they function, what is the value that they bring. And we've had some experiences like that where, our CHWs were not necessarily recognized and their potential, and again, recognized as experts of what they do, and that they bring value to the system. So CEnR, we're working together with CEnR to create these roundtables. I referenced this earlier in my introduction, where we bring clinicians and CHWs together to start having conversations, to introduce us to ourselves, to learn more about what each does and the value and expertise that we bring to the healthcare and public health system in service of good, safe, high quality patient care, community care that ultimately then moves the needle when it comes to health equity and health outcomes, particularly for our minoritized and marginalized communities and populations. So we're really excited and looking forward to those experiences, and I'm very happy to shed more light on that. But the other perspective I wanted to raise, we haven't really talked about it, but I want to talk about age a little bit. I think folks may get the impression that a lot of CHWs are older, more experienced people, and they would be correct. But there are also a lot of young people. And I think that I wonder how we are being intentional about marketing the CHW, I would call it profession in the way that it is, to young folks, as this is a viable option for young people to participate in the healthcare and public health system. And I would say this because I did work with we had a few young CHWs with our Wayne Health program, and it was wonderful because I found myself, whether I liked it or not, in a position of mentoring them. And again, we talked earlier about linking to support the needs and sort of goals, career and otherwise, of CHWs. And these two young, wonderful, beautiful, brilliant people, one wanted to go into public health, and so she wanted to be a public health professional. I believe the other one was the other person was interested in social work. And, part of that, doing that and being a competitive candidate for those programs is being able to publish and show you have some scholarly skills. And so what I did is work with them to translate the work they already do into a manuscript, into an abstract that can be presented in at a conference, so that they started to learn, how do you write, in a scholarly way? How do you present and speak with confidence about what you know, and also confidence about what you don't know, and that's still okay. And being able to communicate your work to the public, and all these are very important skills, frankly, regardless of what walk of life you go into, honestly. All right. And so so those were skills that we were able to start to work on. So I wonder about the conversation about the intentionality, about how are we ensuring that we are bringing in young people into the field, and then pairing them with the support they need to connect to their own health goals, of which are myriad, of which are plentiful and diverse, and lead them across that, along that pathway. And that this could actually be a very important and under-recognized entry point in terms of the pipeline of increasing representation in healthcare and public health.
How young is too young to be a community health worker? Or is there an age? Based on, I'm posing this to the panel based on your experience.
Well, based on my experience as an Ada is the Igbo title for the first daughter of an Igbo family, and that's my ethnic group as in Nigeria. The youngest age to be someone who represents their community and speaks on behalf and advocate for the community is as soon as you can make words. Because we just expect you to be responsible. And so from a very early age, I was in the capacity of what could be now described as, quote, community health worker. We have other names and terms for these people, but people who are able to then speak on behalf and represent the needs of their community. So, but that's a cultural context. In terms of the US, that's a wonderful question. And I wonder, as early as someone can have a job, I guess. But I would love to hear the perspectives of Cheryl and Miss Philesha.
I just typed in the text in the chat. It's age 18,
Okay,
and it's
very good.
a high school diploma. I would imagine a GED would suffice too.
It would.
Yeah.
So
that's good to know.
moderator's privilege, let's talk about it. One quick pivot. How can we bring more young people in? I think as we are looking at the workforce, we have to look at both ends, just starting up and the senior pipeline that we're working on, like at the Hampton Center. So how do we bring a younger population? How do we raise the visibility of CHWs that it attracts, magnetize the role for young people to come into the workplace?
I guess you could start within the school system, like how they have those career prep classes, exploration, just kind of introducing this is another opportunity to enter into the healthcare field. You don't necessarily have to go the track of an RN or a medical student or a scientist. This is entree. So if you decide that you want to go further, at least you will have a very good foundation to help you launch your career further if you so desire. So I think it should begin in the high school setting. This is something, if you care about people in your community, health disparities, inequities, this is a great way to start your career in public health, because it is like entree into public health.
It is. I think that we have to nuance it in a way that, what I've been discussing with people is concerns that, and Ijeoma, your perspective is amazing. I think the fears I hear from some people is that, what's a 16, 17-year-old going to be able to help me with, right? How are they going to have enough life experience to be able to even know what some of these things are. And of course, we know that there are some kids that are schooled way beyond their years, way younger than their years, right? And so we are actually thinking about that. And we started an advisory board at Wayne State a little bit ago, and it's starting to think about this with our advisory board. How do we get this out? So this is a great question. I wasn't actually prepared for. I'm going to think about this and maybe reach out to you all again another time. The one thing we've been doing is hitting up 18-year-old freshmen in college. Now that's a different group of kids who have the wherewithal to get themselves to college, right? And thinking about this as a thing they can do in their first and second years of college. But we've been thinking about this exact thing, is how do we expand it and then also have the public have confidence in people without a whole heck of a lot of, but I'm making a generalization, right? Because a lot of 16-year-olds have way more life experience than some 30-year-olds, right? So that's a generalization, but just trying to think that through. But it's fantastic idea. I'd love to partner with y'all on how to do that. Let's think about that.
Well, even my first response to, what you're saying there, and I appreciate that, right? That difference in maybe life experience, and are they going to be, an important piece of community health workers or this area, as was mentioned before, is people have to be credible, right?
Yes.
So is someone on the younger side to be credible to someone who's on the older side, but they can, work with people in their age group,
Right.
right? Maybe so you have 18 to 30-year-olds working with 18 to 30-year-olds, and that's their lane.
Yeah. So we actually our model at Wayne State in our Community Health Worker Academy so far has been an employer approach, where different employers come to us and say, okay, you've got this health resources services administration money. Can you take our 12 people? Can you take our 30 people? Can you take our 5 people? And we put them together in clusters and train them, and they have the infrastructure in their jobs to go out and have the support and billability to, advance their organization. And but then we're starting to get individuals, like people that are not affiliated with something. And we have a guy from Turning Point in Lansing has found us, and he works with kids. And so he said he is working with very adult issues with 13, 14, 17-year-olds. And so there's a market for all of this. I think we're all just finding ourselves, as Michigan's become Medicaid eligible for reimbursability for CHWs. And it's an open landscape right now that we got to keep developing. Ijeoma, I see your little hand.
My little cute little hand.
It's so cute.
Thanks for that, Dr. Cheryl. I really appreciate that. And, there's a scripture that says, and excuse me, in spirit of being inclusive, this is of the Christian faith, but I'm sure in many faiths, there's a version of this. And even if you're a person of no faith, you hopefully might connect to the wisdom of it. But there's a scripture that says, I think it was Paul that was talking to Timothy and said, do not despise your youth. I'm paraphrasing, pastors in the audience, don't kill me now. It's been a while. So, but essentially, do not despise your youth. All right. And I'm going to Google and get the exact phrase and put in the chat, but you get the point, right? Which is this. I'm also going to borrow from, liberation, Black liberation principles, anti-racism principles, justice liberation principles, community-based participatory action research principles that is asset-based and strength-based. Young folk have a lot to offer. If we start from that as the basis, then we find the opportunity, right? Like when we come through the deficit-based lens to say, well, what can a young person offer an old person through the lens of they don't have something to offer, then they don't have something to offer. But if we ask that question differently to say that, oh, I wonder, with wonder and curiosity and imagination, I wonder what they have to offer us. And Dr. Daly, just beautifully put in the chat that, oh my God, from a technological standpoint, being able to navigate, we have CHWs right now that be struggling. They are gifted and wonderful, amazing communicators and connectors, but you put a laptop in front of them, they freeze like it's not tomorrow. So we're working with that. But the digital literacy piece, the technological literacy piece is important. important, and so it really, matters. There is a lot that they can provide. I can almost put a similar argument. What does a 75-year-old, CHW have to offer, a 15-year-old that comes to visit the healthcare setting from like 7 generations apart? And the answer is a lot, right? But there's also things that elder may not necessarily be able to connect with young people. So as to Dr. Thompson's point around, well, we can match by age group. But to be honest with you, I have been in awe. When I say in awe of young people and their capabilities, I have been blessed to be around some of the most brilliant young folks, and folks especially that come from, minoritized communities. They have seen life, 2, 3, 4 times life. Many people, as you said, Cheryl, who are older than them. So I want to encourage folks that may be asking this question to shift their lens and adapt an asset strength-based lens and approach the question. For everybody has something to offer, and bring to the table. And we can provide training while the lived experience piece is coming, together. So I just really want to lift that, and that we don't despise anyone's youth or despise anyone's age or despise anyone's whatever, because ultimately it is a strength. It truly is. If we see it that way, then we can make it that way.
Well, I'm definitely glad we went down that pathway. So let's get up. Go ahead, Dr. Thompson. One more mile down the road.
I might be taking us into a somewhat different direction, but as we've been talking about, the new roles for community health workers and the ability to be reimbursed for their services within these very specific contexts, healthcare structures and systems. Actually, Arthur and I were at a talk. I want to talk about, we heard from someone named Shreya Kangovy. I think I have that correct. I'll put her name in the chat. Dr. Shreya Kangovy from University of Pennsylvania. She's doing her program is called Impact. She does amazing work around community health workers and sustaining community health workers and careers, right? And she had just talked about this really, her model of community health workers is very person-centered. So even if someone needs to manage their yes, they might have hypertension, but maybe the most important thing for them that day when the community health worker talks to that person is, I'm having issues with my utility bills, or, I'm trying to reconnect with my daughter, and ideas that, work with people where they are on what is important to them. But we also know that that's not necessarily the goal of the healthcare system, right? They might have a different kind of view on what that community health worker should be doing. And she raised this issue about being vigilant about having healthcare systems and these institutions co-opt kind of this community health worker model. And I just was curious if that resonated with anybody on the panel, and what, how you might respond to something like that. Because again, we talked about the history of community health workers. The literature sometimes call them natural helpers, right? People who might be doing this work anyway, right? Now we're giving them a title and maybe they have a certification. But when we're placing them in certain professional contexts, the expectations maybe shift and change. What are your thoughts about that?
I sent you real quick, and Ijeoma, I don't know if you were going to speak, but I sent you all the national training roles and competencies. And the reality is, and this is why I was saying earlier, I would love to collaborate with this panel and anybody else who wants to discuss getting younger generations involved so we can have a wide gamut. But the reality is everybody's going to get trained in the same thing. They're going to get, and I sent what those trainings are, and everybody's going to get the same background, and they obviously bring their own lived experiences. And so we can just highlight that. And I don't know, I actually lost track of where we were going with that, Hayley. Sorry, I got myself all turned around.
So let's get back on track. We're at the bottom of the hour within our last 24 minutes together. So let's get to some more questions. We've kind of talked about barriers and challenges that community health workers encounter. What are some examples of leadership roles? How can I navigate my CHW experience into a leadership role? And what are some of the greater opportunities that are available in leadership for CHWs?
Well, I can only speak from the Henry Ford standpoint. There are leads in community health, like a lead for the for that hub. But if you're talking about managerial, once again, you're going to have to go back into getting that the degree in order for you to navigate in that leadership space. I haven't seen anyone with a CHW escalate into managerial without having a degree. So it's a great launching point, just like with anything else. You're going to have that extra education, continuing education. Of course, you could take leadership seminars, webinars, attend conferences, but if you're talking about leading people on a managerial level, I just know from my own experience that you're going to have at least a bachelor's degree in order to be considered in the healthcare field.
Yeah. Just to build upon that, and also there's a question in the chat that's related to this about the role CHWs can play in research and data. I think that certainly there are benefits to having those degrees, but I strongly believe that those things are not necessary. Shouldn't have to be necessary. They shouldn't have to be mandated, right? Especially when I think about a lot of health equity research in the space I'm in, doing behavioral and community-based research. A lot of that work is focused on interventions, right? Actually, what's an intervention? It's a program or an approach or a strategy to change something, whether it be able to change a behavior or change a community sometimes. But those interventions, especially when we think about some of the challenges in health equity and working with minoritized populations and populations that experience disparities, there's an increasing need to have people who are represent or somehow similar to those communities do that work. And I think it's just an ideal space for a community health worker to engage, especially because, again, it's an intervention. It's a tool that hopefully that community health worker can use. So whether it's, a lifestyle intervention to get people to eat more, 5 servings of fruit and vegetables a day, or it's something around maybe smoking cessation or increasing physical activity or getting screened for breast cancer. I think there's a really, really important role that community health workers can play in that now. And I think that some type of research training, like what we try to offer and try to extend, is important, because when you think about an intervention, there are things that are important, like fidelity, right? Interventions have to stay consistent as the way you kind of, when you share them with people or when you deliver them to different groups. There's usually some type of data collection around an intervention, right? How were people doing before the intervention? How are they doing after? And again, I think there's a lot of space for community health workers to serve as research interviewers and to participate in different ways in collecting those data. So if that's something I'm working here at Wayne State, I would like to see us work together to grow those opportunities. And I've been having this conversation with our HR people. What are the designations within our human resources so that people don't have to have a bachelor's degree, but if they have the appropriate training and experience, and still come and work in those settings.
Yeah, and it's like that with Henry Ford. If you have
Yeah.
a high school diploma, GED with experience, but you asked the question about moving up the ladder in terms of managerial, you're going to have to be degreed. I worked on a previous project on helping seniors to navigate their pain using walking and other interventions. My colleagues are CHWs, a lot of experience, no degree. One is working on getting her, she's mid-60s, working on getting her bachelor's degree through Wayne State in community health. She knows that in order for her to advance her level of expertise, she's going to have a degree. But to do research wholeheartedly, 100%, Dr. Hayley, you want people from the community in order to, do the work of research. That's how you get buy-in. If you see people like yourself doing the research, you're going to get higher participation, better outcomes. So I agree with you wholeheartedly. I mean, this is a great career for someone, a second career for a senior that's retired and really wants to stay active. This will be a great entree for, introducing, dispelling health equities, helping people to understand the research and how it can really impact their health outcomes.
So I
agree wholeheartedly.
I want to get to Dr. Opara's question, and then we're at the time in our schedule where please begin to leave your questions in the chat, and I'll begin to address those. But Dr. Opara, your comment.
Yeah, no, I was just actually going to reiterate in the chat, and thank you, Dominique, for that question. And everyone has really responded beautifully to it. I just wanted to reiterate the resource that was placed in the chat, which is CHWCRE, and that's the CHW Research Center for Research and Evaluation. And what they do is that they have created essentially common process and outcome indicators for CHW practice and integration into research and evaluation. So just that's a great resource to look at. And from my personal experience as a researcher working with CHWs, indeed, like Ms. Philesha has said, it only increases the quality of the work. And as Dr. Hayley has said too, in implementation science and intervention science, our CHWs collect data through their screening of social determinants of health. They help in giving feedback. They actually helped in curating the screening questionnaire itself by providing feedback, working through an iterative process. Then as they do go through the process, they provide feedback to the process itself. And is this working? Is it not working? Is it making sense? How are people receiving questions or not receiving questions? They're also giving feedback to what they need to do the work effectively as well. That's all important data for the work and the implementation and to be successful in the implementation, of it. And they also help in terms of the proposal writing itself, and participating to the degree that they're comfortable with. Some of our CHWs are also on CABs, on our community advisory boards as well. So they also participate in that capacity. So to the point, I mean, all phases of research, they're critical too. And I would say the manuscript that I was working with my CHW colleagues, they are co-authors on the dissemination of the research as well. So all phases, every phase, there's best practice to guide that integration. And again, it only increases the quality of the work.
Okay, let's get to a question in the chat. If you are degreed in management and mid-level career, in what ways can a CHW elevate you to the next level? Or would you say it would be more in line with training others?
I would think you probably more in line of training others, because the CHWs is really gaining a lot of popularity, especially since COVID. Even social workers that are licensed and nurses that are already licensed, already doing similar work, are getting the CHW credential. So it's just really what's going on right now, and with us being able to be billable, it's just making us more viable. So I mean,
Yeah.
That's what I'm noticing. You really don't have to, like, you don't have to, if you're already a nurse, it really doesn't make sense for you to get a CHW
Right.
certification. It's entry, public health. You're connecting people to resources. You're like a liaison. But
Yeah. And so like
the billability of it, because it's billable now,
yeah.
people are, saying, okay, I need to have a CHW. I already have a master's in social work.
Yeah, and Philesha, I just had a couple calls recently for people thinking they needed it. And I'm like, no, you don't need it. You're already credentialed to do
Right.
higher, actually more intricate work with your MSW. So we're steering people away, especially not to use the resources on people that, if you're not going to practice under the profession of the CHW and your main credential is still going to be your social work degree, then it's not the place for you. And you have already had that training. But to answer Rick's question, hi, Rick Zimmerman. He's in nursing and associate dean for research. And he asked a great question about how do nurses interface. And we are about to hire 2 of your bachelor's students that I think are sophomores that want to go. One wants to go into a hospital and healthcare administration. And so it's like, she's going to get a couple years of work doing work on our education catalog and following our trainees and helping to curate trainings and work on our specialized certificates and in the areas of healthcare, medical care, care like that. But in terms of the actual practice, I think it's kind of like what Philesha was getting. They're complementary.
Exactly.
roles. Yeah, and
Exactly.
you're going to work together and
Yeah.
understand each other's roles. But one of the things that I think is the elephant in the room when we talk about research is unless you have a position, unless you're comfortable, if somebody can spend their time volunteering, unless you have a position that's paid, it's reimbursable in some way, or it's funded by some external source, it's hard to fill it with somebody who just wants to do volunteer work. And a CHW in research or other places, it's going to be generally some kind of external or internal funding that allows them to do that. So I don't know, Hayley, you're the master at getting that going, but that's like the elephant in the room there. And I don't know if Rick, I answered your question well enough, but it's kind of like a conduit to like what Philesha's saying, people in nursing could start out getting that experience. And this is what I really want to do, is figure out how to get youth into what we're doing, because whether they stay there forever and just keep advancing. And you guys, I have 140 trainees so far, and the salaries that they make are widely varying. I mean, we've got people making $15 an hour, and we got people making $28 to $36 an hour, and they're not in manager roles. So the managers are obviously making a lot more. So that's like a wide variability in terms of, where you feel valued for your work and stuff. So anyway, I don't know if Rick, I answered that enough. We can talk offline. Dr. Daly.
Scanning here to see if there's any more question. This panel discussion has given me so much hope and reassurance about a post-retirement second career. I appreciate all the information that was shared. Please, everyone, go scan through the chat and connect with all the links that have been shared. A lot of great resources have been shared for your edification and advancement. As we approach 7:50 and approach closing, I want to open the floor for any last questions.
Well, I do have a statement. Someone mentioned the youth before. Excuse my voice. But it's the youth are a great tap into that resource, Cheryl. And Dr. Opara, you just talked about CHWs having, issues with navigating their computers. And there's a way. Remember how candy stripers existed back in the day, where they were in the hospital to serve whoever. I wanted to be a candy striper. That never happened. But I did graduate from medical school, so I did make up for it. But my point is that there is utility for the youth now, so tap into that. I witnessed my kids trying to help their grandparent navigate to make sure that she can look at her medical records. And it was something she so appreciated. But they were like, yeah, it's so easy for us. But other people, I mean, there are so many ways you can utilize them, and they can actually be trained in that to help with other CHWs. So this is a thought, just to think about how to utilize them because when they're exposed to healthcare and taking care of people, they're going to be so much better when it comes, better citizens, better people, better characters, period, later on in life. So
we do have a new question in the chat. Thank you for that. How do I find more information on becoming a trainer?
I just put something in the chat. Hi, Elena. Good question. I mean, once you have the CHW credential and you have I think it's 3 years, does Philesha or somebody else know for sure, of practice, you can become a trainer through MISHWA. You can be a trainer through another group called Everyday Life Consulting. Both those groups are state, like certified isn't the right word, but approved to be creating trainers and creating like licensing people or giving training, being trainers. So
I would just, concur that go through MISHWA, and then there's the National Association of Community Health Workers that gives you the latest and greatest legislatively and all the things that's going on in the CHW space.
Naya, it takes like MISHWA's certification program is 16, 17 days of training. Everyday Life Consulting does it in 12, but Mishwa, we use both in our academy, depending on what's going on in our capacity. We have one full-time master trainer working for us. When she's over capacity, we contract out, but but Everyday Life Consulting doesn't bring in or doesn't build in any group or project time. You do that on your own. So it's like between 12 and 16 full days of training. It is the typical structure. Some organizations right now, we just started a cohort on March 13th and March 14th, once a week for 12 weeks. We have a cohort starting June 2nd that goes 3 days a week. And how fast do they get that done in a month? We have a cohort started, I think April 3rd they started, and then they might be twice a week. I can't remember. So there's, that's a quick answer. I hope that's quick enough.
And, you know, I also attended Everyday Life's graduation ceremony. It was virtual yesterday from 4 to 5. So it was wonderful seeing the new CHWs getting their credential, being celebrated, and sharing why they're so excited about coming into the field and the joys and pain that they've navigated. So it's really amazing to see people come into this field. And it's so much opportunity here for people to come in and be difference makers as CHWs. With that, I want to see if there's any last questions from the audience. Just raise your hand, turn your mic on, and ask your question if there's any questions. Seeing none, I will surrender the floor to Alex or Dr. Thompson. Do you have any parting comments, any parting summative comments from the panel before we wrap?
No, I just want to thank everybody for a lively discussion and dialogue, and I hope that everyone got something out of it. This is, again, our first night of our Community Engaged Research Summit, and we're continuing tomorrow at 9 a.m., 9 to 2, where we're going to continue to have other panels and speakers, so we really hope you can join us. I really want, and I should have done this at the top of the meeting, I apologize. I wanted to acknowledge also our planning committee, and particularly Benji Rapp and Dr. Maha Albdor, who are the chairs of the planning committee, and I know there are others who are on the committee, Dr. Outlaw and Zimmerman, Arthur, yourself, and others. So I apologize for not doing it at the beginning, and we'll acknowledge all the members tomorrow, but just wanted to invite everybody to join us again tomorrow for activities and our discussion. Everything is virtual, and thank you.
Thank you so much for everyone for coming. Have a good night.